just to recap on a little bit of immunology. So if you look at immunology textbooks or publications, you can see quite complicated pictures and slides involving all sorts of terms and cytokines and numbers. But you can make it quite simple. And there's some key things that have been mentioned by Sharon, just to reiterate. So sensitization. So this is quite important in terms of allergy and also EoE. And that's where the immune system sees something. Now it's designed to see bugs and pathogens and deal with them, but sometimes it can see things that are innocuous, like agents that cause allergy, we call them allergens. And they sometimes get seen by the immune system, usually because the barriers that are normally there to that break down or don't work. And that can be through environmental or genetic conditions that just mean these barriers don't work, whether that's the skin or the gut. So these allergens get through and get seen by cells that maybe shouldn't be seeing them. And they go through the process of dealing with this agent and pretend just in the same way it would do as a pathogen. Now, mast cells, Sharon's talked about, so they're the key cells involved in type 1 or Ig mediated allergy, so hay fever, etc., food allergy. But there are other important cells, that work in the background, and particular ones are these antigen presenting cells, the T cells, so these are a special subset called helper T cells or CD4 T cells. These are the cells that HIV attacks that causes AIDS. So I call them the orchestra of the immune system. If these don't work, everything falls apart. And if they're working appropriately, you get autoimmune disease and you also get allergy. And what they do is they talk to these other cells called B cells. These are the cells that go on to make antibodies. And there's quite a close interaction with these T cells and B cells. They have to touch each other and interact, and they produce these soluble things called cytokines. And it's the type of touch and the type of cytokines that really determines what this B cell does, whether it makes an IgE antibody or IgG4 antibodies or other antibodies like A and other types of IgG. And that really helps determine what the end result is, whether it's allergy or tolerance or responses to vaccinations like the COVID vaccine. These are also important in generating eosinophils, and that's where they come into EoE. So one of the big questions in EoE is, food is an important trigger, possibly pollen. Why is it we're making an abnormal immune response to them where the outcome is this eosinophilic inflammation? And maybe these mast cells and Ig aren't that important, but we'll talk about that in later slides. So I've covered that. And just to reiterate, so these are very important, these antigen presenting cells, they're very specialized. Their main role is to present proteins to these CD4 cells, and they've got the armory to do it well normally. These are the helper cells I talked about, and the B cells that are important in generating antibodies. So IgE in terms of allergy, but other antibodies too. So Sharon said, we thought initially that IgE allergy was relevant to eosinophilic esophagitis, and we were initially doing skin testing, and in my allergy clinic I was starting to be referred lots of EoE patients just for skin testing, see if that could help decide on dietary intervention, but it really doesn't work. It's not helpful. There's no need for that in that context. But as Sharon said, these patients are atopic, and my adult cohort, quite a lot of them are atopic, and we'll talk about that later. And for those reasons, you do assess them from an allergy perspective, just in the context of their other comorbidities like eczema, food allergy, rhinitis, and also in deciding and helping the dietitians with dietary intervention. Because if you're eliminating foods, you want to supplement them with other foods, and you don't want them to be allergic to those other foods and causing problems. So what's the classical adult? Well, adults are slightly different to the children, but there are a few things in common. So there are more males than females, and you see that in pediatrics too, I think. A lot of my patients have had symptoms for a number of years, and quite often there is a history of atopy of some kind, so hay fever or food allergy or eczema. Diagnosis usually, so a lot of my patients, it's followed hospital admission for an impaction. And quite severe symptoms, and particularly those who've had it for many years, they're put up for it, mild symptoms, but then they get their impaction, go to hospital, and that's where it gets diagnosed. So diagnosis is often delayed for a number of years. I think my longest is about 25 years of dysphagia before they impact and it gets diagnosed. So our Southampton cohort, this is all adults. We've got about 140 patients now with EoE. I started seeing patients probably about 7, 8 years ago, where I'd get the odd 1 or 2 in my allergy clinic, and then it was 3 and 4. And soon I was doing my clinic into the afternoon because I was seeing these EoE patients at the end of my clinic, and so set up a separate clinic just for this. The age range is quite broad, so 17 to 75, more males than females. And a lot of them do have a history of atopy, but not all of them. So a reasonable number don't have any allergy history. And in terms of seasonal variation, so hay fever 42%, but only about 6% of our cohort experience worsening symptoms during the pollen season. So it's not all of them, but it is, you know, a relevant population. So can aeroallergens, so can allergens that breathe in, the same allergens that cause hay fever, rhinitis, can they trigger EoE? Well, there are actually a few research articles looking at animal models, mirror models, where what they do is they sensitize them, so they expose their immune system to aeroallergens, usually through the skin route, epicutaneous route, and then afterwards they challenge them nasally with these same allergens, and they showed that actually with nasal challenge they develop esophageal inflammation, and that's eosinophilic inflammation. So there's some link. You know, could it be that in humans, in patients with hay fever, breathing in the pollen can generate esophageal inflammation? And as Sharon said, there is iatrogenic evidence. So patients that undergo oral immunotherapy, usually to pollens, dust mite, and also food desensitization, where orally they're exposed to food allergens, there is an increased incidence of EoE developing in these patients. So is there a link there? Now, in terms of research to look at it, it's quite difficult to tease out what's going on, because these patients get variable symptoms. It's hard to diagnose the inflammation because they need an endoscopy and biopsy. We know symptoms don't correlate with disease activity. So there may be patients who say they're fine during the pollen season, but if you biopsy them, they may have a lot more inflammation. That data is difficult to get hold of. Some studies have looked with a diagnosis of EoE, thinking that maybe we'll see more seasonal variation from increased diagnosis in the spring versus other times. And one paper showed, yes, we saw more seasonal variation in diagnosis, but another paper didn't really find that. So not so clear cut. So is seasonal variation important? Well, my personal view is probably it is, but only for a certain subgroup of patients with EoE, not all of them. And it sort of makes sense, because we see patients who do really well on diet, quite a high proportion do. And if aeroallergens were that important, you'd see more dietary failures. So I think it's a certain group it's important, but not in all. Future research, well, I think it might be worth focusing on those that do have symptoms, just that group, and just see what's going on. And if you look at a lot of the publications, they're focusing on eosinophilic inflammation, but what about IgE mediated inflammation? So these patients are inhaling pollen, swallowing it, they've got these IgE antibodies to pollen, there are mast cells in the esophagus. So could it actually be that the mast cells are causing swelling on top of the eosinophilic swelling that's exacerbating their dysphagia? So histamine is an important chemical that causes swelling. If you have hives, you get swelling on the skin. That's mediated by histamine. There's another chemical called bradykinin that mast cells can generate, and that's very important in swelling, something we call angioedema. And could that be going on in the esophagus as well as the eosinophilic inflammation? And that's something we're interested in. We want to look at after COVID, when research gets back to normal. But certainly that might be a possibility too. So now I'm going to talk about diagnostic and management dilemmas. So as we've said, um, clinical symptoms, so degree of dysphagia, how often they get dysphagia, is a bit difficult. Can you hear me okay?
We lost you for a second there, Efrem, but you're back now.
I'm back now, okay. So how do we assess these patients? So symptoms don't correlate with disease activity. You can't see it. It's not like an eczema or urticaria. You can't look at it and see how aggressive it is. And really the only way to determine the degree of inflammation is endoscopy and biopsy. And it's particularly important in food elimination diets where these patients may be eliminating a number of foods. You want to reintroduce them and assess the response to that food elimination. Really the only way is being biopsy, and that can be quite difficult. In adults it's difficult. What about children who usually need an endoscopy and biopsy under general anaesthetic? So it's quite difficult. So what can we do? Well, there are classical changes on endoscopy that you can see disease activity, but the problem is in about 50% of patients it looks normal. So it's not helpful all the time, and once again you need to scope them, and really you would need a biopsy. As we've said, symptom scores don't really correlate. That's been published, and that's also our personal observation. So symptoms don't correlate with disease activity, and there are various explanations. So patients will modify what they eat and how they eat. So they may have dysphagia, but they eat more slowly. They have water with their meals. They'll avoid bulky foods, and so their dysphagia score will naturally go down due to that, and sort of fool you in terms of the degree of inflammation that's going on. Dysphagia scores I still think are important. So we use in our clinic just a simple dysphagia score. There are more complicated ones out there, but if you're in a busy clinic, you really want to have just a sort of a quick score. So we've adopted this, but we've added other questions just to gauge these changes to lifestyle that patients may undertake to avoid dysphagia. And one is having liquids with what to help them swallow. And that is a really important, useful thing to find out, because quite often patients may have not much dysphagia, but they always have to have a glass of water with their meal. Changing the way they eat. So do you eat more slowly? Does it take longer to finish your meal? That's another one. If they're specifically avoiding food, bulky triggers. And do your symptoms affect quality of life? I've heard a few patients who've said no dysphagia, but they say, yes, it does. And then you ask why and engage in them, and other things will come out. So maybe, they're worried they can't go out and eat in a restaurant because they have less control over what they're eating. And they're worried about getting an attack in a restaurant and being embarrassed by having to go to the toilet and choking, etc. So what can be done and what's on the horizon? So ultra-thin nasal endoscopy, actually I'd not heard of until recently. I had an endoscopist sitting in clinic with me who said, well, why don't we do this in clinic with you? So I looked into it, and there's quite a lot out there. There are a few YouTube videos and children having this procedure. It looks relatively very simple. There's a very interesting YouTube video where actually they're using goggles where the child can play a video game while they do it as distraction. And it's quite a thin scope, so it's a lot thinner than the ones used for normal endoscopies that goes through the nose. Not invasive, and it can be done in outpatient clinic, and you don't need, in terms of children, you need a general anaesthetic. So it's very useful. You can look to see the changes that might indicate esophageal inflammation. You can also take biopsies with it. So this could be useful in the clinic, and something I might be looking to introducing into my clinic, because I think it'll be very useful. The next thing, and this is something I'm particularly interested in, is there an even easier way to monitor disease activity? And really I started thinking about this when I started seeing patients with EoE. Being an immunologist and working in the immunology lab, we're dealing with tests to monitor disease activity for a number of things, including allergies and IgE. And we just thought, well, what about the cells that cause inflammation in EoE? Well, there are eosinophils, of course. You see mast cells, basophils, lymphocytes, and all of these produce various chemicals that we can measure in the lab. So could that be a way? And at the same time, this paper came out by Futura in 2013, where they did just that. They looked at eosinophil-derived proteins. So these cells are inflammatory cells that you find in EoE in the esophagus, and it's part of the diagnostic criteria to get more than 15 per high power field. And within these cells, if you look at the microscope, they have these two dark globes, these are the nuclei, and this sort of pinky cytoplasm, and that's full of granules. And within these granules are various proteins. So one's called major basic protein 1, eosinophil peroxidase, eosinophil-derived neurotoxin, eosinophil cationic protein, and Gal-10. And there are lots of others too. So in this paper, what they did is they looked at these mediators, and when a basophil's agitated, it degranulates in the same way as mast cells do in allergic reactions, and releases these chemicals into the tissue, but also into the lumen of the esophagus. And what they did is use this string test, an enterer test. Now, this was developed many years ago, I think, to diagnose Giardia, which is a bug that lives in the small bowel and stomach. And what they do is swallow this string and then pull it out after a while and look for parasites, the Giardia, at the end of the string. It's also used for reflux, where patients would swallow it and lie down, and they'd measure the acid, so the pH of the string, and how high it went. But it was adopted by this research group to absorb these eosinophil-derived proteins onto the string. It was mainly children, and I think they had the string, swallowed it overnight, and then they pulled it out and looked at these biomarkers. And what they did is they compared active EoE disease versus treated patients with EoE versus patients with reflux versus normal patients without any disease. And they looked at string test biomarkers, and they looked at biopsy, eosinophil count per high power field. And essentially they showed that in active EoE, these biomarkers were high, and all of them were high, except for ECP, and we'll talk about that in a minute. If you treated them, the biomarkers went down, and in just simple reflux and in normal patients, you didn't really see significant levels of these biomarkers. So essentially a very good test, very easy to do, non-invasive, doesn't need an endoscopy. And this has recently come out where they've gone from overnight to an hour. Similar sort of study, but involving adults, so 74 children, 60 adults, looked at similar biomarkers again, and they showed the very good correlation with biopsy results. And also patient satisfaction, so children 87%, more so of their parents, and 92% of adults all preferred the string test over endoscopy, understandably. So essentially this test, the levels of inflammation correlated very well with biopsy. So now you've got a marker you can use in clinic, a test you can use in clinic that's as good as endoscopy essentially in terms of looking at eosinophilic inflammation. Now it doesn't discriminate. So there are other diseases that cause eosinophilic inflammation of the esophagus. And I think the role for this isn't at diagnosis, but there is a role for it in monitoring disease activity. So I guess it would be dysphagia, have a scope and a biopsy, exclude other causes, diagnosis of EoE, but follow up with these simpler tests like a string test. Now, what's interesting is ECP, eosinophil cationic protein, didn't work in the study. And I was really disappointed when I read it, because I work in an immunology diagnostic lab, and the one marker that you can use, so any lab that does IgE testing, and that's mostly in a lot of the big NHS labs that can do IgE testing, can very easily do ECP testing, while all the other biomarkers are quite difficult to introduce in standard practice. So I just wasn't sure, why did this not work? Because there's loads of it in eosinophils, so why couldn't you pick it up on the string test? And what we did is we looked into it, and actually we did our own string test. We call it assessed. And it's slightly different in that the string is not nylon, it's made of another material, and it has a coil at the end. And the reason there's a coil is I didn't like the idea of a gelatin capsule, because patients with dysphagia sometimes can't swallow tablets. They won't be able to swallow a capsule, and children can't swallow tablets. So we designed something that actually avoided the use of the gelatin capsule, and the coil works really well. Adults can swallow it, and we've just been trying it in children, and a 6-year-old who can't swallow tablets was able to swallow a string test, and it worked very well. So we modified the string, and we modified the way it was processed and tested it on things that most NHS labs could do. So the theory was, we'll revisit ECP, but just change the way the string's processed. We looked at calprotectin because there's a little bit in granulocytes in the esophagus, so we thought that may work. And we looked at tryptase because there are mast cells in the esophagus, and tryptase we use because mast cells do release a lot of tryptase, and we use that in the allergy clinic for anaphylaxis and other things. So, and these are all readily available tests. Tryptase, undetectable in every patient I've tried, so we crossed that off. Calprotectin worked a bit, but if there's any little bit of gingivitis or bleeding in the gums, you get a sky-high false positive result. So we just cross that off. But the ECP, with the processing we do, works really, really well. So we've stuck with that because we can readily do it in the lab. And these are just some examples of the patients we've tried it in. So this is the ECP level, and it varies. So the highest ECP we had in a patient was 4,000. Normal is less than 100. And when you correlate with the biopsy result, here, quite often the histopathologists report less than 15 eosinophils per high power field. And generally, if it's less than 15, they're going to be less than 100. And then you have these in-between ones. So where you've got 80, 60, 40, you get a relatively comparative ECP value. So it works very, very well. And that's what we've been using for the last 6-7 years. So as I said, the main role I feel for the string, the main way we use it is monitoring response to treatment. So whether it's topical steroids or particularly diet, we're using this to monitor response. And we only ask for an endoscopy if we're not too sure whether the string test results correlate clinically. So maybe if there's something odd going on, we'll ask for an endoscopy and biopsy, but always the endoscopy and biopsy fits in with the string test result that we've had so far. We've done about 1,000 patients and really no real problems. Only one person's ever swallowed a string test and it was fine. It just went straight through. And so it's great because, as I said, most labs can do ECP. It works well in a clinical setting. It's not one-upmanship, but we do 30 minutes because it fits in well with clinic, and we've done time courses. And actually with ECP, 30 minutes actually works very well. Mostly adults, but as I said, we've done 3 children. We would have done many more, but COVID's put a stop to endoscopies. And being a little bit of an issue at the moment because we're not doing clinics, but I'll talk about what we're doing towards the end. Just some examples of how we're using this. So this is a patient, age 50, diagnosed with EoE in 2016. Lots of inflammation, so 100 eosinophils per high power field. String test high, 800, which would fit with that. We do this dysphagia score I talked about earlier. It's out of 14, so a high score of 13 out of 14. And she was started on the 6-food elimination diet. A very motivated patient, wanted to try the 6-food elimination diet. And after about 10 weeks on that, dysphagia score went right down to 1 out of 14. So as I said, it doesn't always correlate with disease activity, but in a lot of patients, the dysphagia score actually does correlate with disease activity. And so we still use it. And in her case, it went right down. We were able to reintroduce foods with ECP monitoring. So that's here. So ECP went from 800 to 45 on the 6-food elimination diet. Then we brought in fish, 10 weeks or so, retested, ECP still low, reintroduced milk, then wheat, then soy. Similarly, with each reintroduction, no rise in the ECP level. Currently, we're on peanuts, which is causing a bit of indigestion. She's starting to reintroduce it. So I think that might possibly be the trigger. Watch this space. This is another patient. He's one of our high ECP. So his ECP was about 900,000 when we first saw him. He was getting lots of reflux symptoms. And we, as a general, we do start patients on proton pump inhibitors first line. And his ECP went right down from nearly 1,000 to just under 300 on treatment. His dysphagia score was only 5 out of 14, despite this high ECP. And that went down to about 3 on proton pump inhibitors. Because there was still some inflammation going, as I said, normal was under 100, he was near 300. We added in a budesonide, and with that, his ECP went down essentially to normal, and his dysphagia score was only 1, feeling really well. But this was again another motivated patient who really didn't want to swallow steroids and wanted diet. So saw the dietitians and went to an elimination diet. Now, we like them to have some disease activity to monitor response. So we stopped his budesonide. His symptoms went up to 3, his ECP went up to about 250, and that was enough for us to start the diet. And on that, after about 10 weeks, he went on just wheat and milk. Symptom score went right down to 1. ECP went down to normal. We then reintroduced wheat. And once again, just on milk exclusion, ECP normal, dysphagia score low, feeling really well. And we also stopped his PPI, and he's doing well. So very easy to do. We're doing it regularly in the clinic. But with COVID, where we're not seeing patients face to face, that is a bit of a problem. But we've just started sending kit to patients at home. So the string test, the tube, you put it in, and that'll be starting shortly. So watch this space. Any questions?
Thank you, Efrem. Brilliant presentation, and very exciting to see how the future of EoE may well change